Well, Croeso welcome to you all. I'm delighted to be having a conversation today in slightly different terms than I might have been expecting, but a conversation with my predecessor in this role as the director of the Welsh Institute for Health and Social Care, Marcus Longley. Marcus, how are you?
Not too bad, Mark. Thanks. Yeah, great. Just about coping with this remote technology.
Yes, a different form of conversation than we might have been expecting, which I'm sure we'll touch on as we go through. The reason for us getting together is to celebrate Wisk's silver anniversary. So Wisk is 25 years old this year, this autumn, and we wanted to put together a package of things, including this conversation, just to remind people, I think, of what Wisk has been up to for a quarter of a century, not twiddling its thumbs in any way, but also to think forwards a bit and to use the experiences that we've gathered through all of the work that we've been doing to think about Welsh health policy in particular, based on Wisk's evidence and intelligence gathered over that time period. Marcus, just tell me a bit though about the people. We must have engaged, getting on for, I don't know, 100 people have come through the doors of Wisk in some form or another over the last 25 years, I guess.
Yeah, I think you're probably right, Mark. One of the great strengths of Wisk, I think, has been that ability to attract people in to do particular pieces of work, and that sort of, revolving door, if you like, between academia and the service, because that exactly is where Wisk wants to be, isn't it? With one foot on either side of the line, as it were.
And Morton Warner was the kind of architect of Wisk. I'll come to the naming of Wisk separately in a moment, but just tell me a bit about Morton and Wisk's genesis, if you like, in the mid-1990s.
Yeah, so as you say, Wisk was set up by Morton and I and one other. I think the three of us who were there from the word go, and it grew out of something called the Welsh Health Planning Forum, which was a bit of an innovative setup, really, that John Wyn Owen, as the head of the health service at the time in Wales, had set up. And the purpose of the Welsh Health Planning Forum, not dissimilar from Wisk in many respects, was to achieve a really effective mix of people from different backgrounds, different experiences, a heavy focus on the practicalities of making strategy work. In that case, predominantly in the health service, because it grew out of the NHS. So that was the origins, and then we were blessed with the Right Honourable Dr. John Redwood MP as the Secretary of State for Wales at the time, and he firmly was of the opinion that he would do the thinking for the health service in Wales, thank you very much, and promptly abolished the Welsh Health Planning Forum. And from that point on, we joined the University of Glamorgan, as it then was.
So one of the key things about where we now find ourselves in policy terms is the whole integration agenda. And in Wales, that is integration of the two parts of the public service, but also the voluntary sector and the independent sector as key partners. So 25 years ago, why did Wisk end up being called Wisk and not something different?
I think in the time of the Welsh Health Planning Forum, it became clear really that term, Welsh Health Planning, was too tight. It was like wearing, a shoe that was two sizes too small, really. It was pinching the toes, if you like. Because even in the work of the Welsh Health Planning Forum, it had become clear, whether you were talking about services for older people or children, or even something as, apparently technical as cancer services, you couldn't really consider those properly without looking at social care, without looking at the voluntary sector, and quite often broader than that, education and so on. So it was a lovely opportunity, I think, when Wisk was set up to get the name properly calibrated to reflect that reality, hence health and social care.
And one of the things that I've been reflecting on is that it might have been the Welsh Institute of Health and Social Care, but it was quite deliberately the Welsh Institute for Health and Social Care, which I think struck a tone of that application of research into practice that Wisk has always been about.
Yeah, I think, what motivated us was a number of things, but one of which was to make a little bit of difference. I don't think any of us at the start and probably throughout have been interested in research for its own sake. It was all about how do you make things better in the real world, but bringing an evidence base to bear in that task. So it was that balance between being true to the best principles of academia, objectivity, evidence, impartiality, but all the time saying, so what? What differences could this make?
And that's a theme I'm hoping we'll return to as we go through our conversation. I'm hoping a number of people will stick with us for the duration of the conversation. I think it'll be a test of their mettle in one way, shape or form if they do get to the end. Half an hour spent in our company, Marcus, is enough to put most people to rights. I won't say any more than that. One of the things, though, that is really important to say by way of our particular context today, because, who knows, maybe we're looking at this in the future, is that you and I are not in the same room. We are at a distance one from another, and that relates obviously to the situation around coronavirus and the social distancing and lockdown measures that have followed from it. In your 25-year experience as part of Whisk and before and after, have you ever come across anything that's impacted on the health and social care system in quite the way that this has?
No, I think the short answer to that, Mark, is no. And everybody I talk to in the health service who's been around a while will say exactly the same thing, and also very conscious of the fact that we're probably still only in the middle of it now. We can't even see the end of this yet, can we? And who knows what the future will hold. I think it has been unparalleled. It has strained the health service in ways which it's never been strained before. The staff in the health service in particular are tired and weary and worn out from it all, really, that constant anxiety and uncertainty about the future. And it's been a roller coaster journey, if that isn't a cliche. Almost every week in the early months there was a new crisis. Would we have enough PPE? What about testing? Could we guarantee the supply of drugs, etc., etc., etc. Almost every week there was a new existential challenge thrown up. Any one of which, would have been, a big issue in anybody's career. And here they were coming like, trains through a station. So it has been an unparalleled time, I think. But mercifully, the health service has, so far at least, survived incredibly well, I think. When you look at those early predictions of the impact from the modelling, you could see a health service that was going to collapse, really. We would have been repeating Italy's experience. That hasn't happened, but it's been at a huge cost. Waiting lists, for example, are rapidly rising now and little prospect of them coming back under control, etc., etc. So, yeah, it's a huge challenge, I think, unprecedented and still not yet finished.
And I think it's also worth reflecting, isn't it, the community aspect of the care spectrum that you were talking about earlier on, that in the social care workforce, in care homes, in home care services, and all of the ancillary support services that are provided by the voluntary sector that help glue our communities together and help provide respite for unpaid carers who I think, have done an gargantuan amount of work really to carry on supporting the people that they care for and love. There's been a parallel, hasn't there, between that effort that you've described and that weariness that you describe and those people in the other parts of the workforce as well, needing to find something now to carry them through what will, as you've said, be continuingly challenging times.
Yes, I mean, my hope would be, this is perhaps a little bit overstating the case, but the health service was born out of the Second World War, wasn't it? It was a fundamental shock to society which led to something very different and very powerful. My hope would be that if anything good comes out of this COVID experience, it might be a serious look at the sustainability and the purpose of social care in its broadest terms. We know that the financing of social care is completely inadequate. It's not on a secure basis. Wouldn't it be wonderful if out of the spotlight which COVID has cast on that, if we as a society come up with a sustainable and fit solution that we can be proud of for social care, a bit like we created the health service all those years ago.
And that will have a knock-on effect, won't it, for people, citizens, service users, carers, whatever labels we choose to apply to them. It is the people who are most impacted on by services that will benefit from that security. And that theme has been something that it would seem connects a whole host of activities that Wisk has been involved in over the last 25 years. I just wonder whether you reflect on words like co-production, which has entered the lexicon, certainly the policy lexicon, and now beginning to permeate through into more everyday type conversations. It wasn't called co-production 25 years ago. What's your sense of Wisk's contribution to how the voice of the individual citizen, service user, carer has been amplified through our work?
Yeah, I think that's a really interesting question, isn't it? And co-production is a bit of a forbidding term, really. You know, it's a bit dry, and what on earth does it mean? And I think it's actually quite revolutionary, really, because it speaks to the whole relationship between services and those who are there to benefit from them. And it's about recasting that relationship completely. It is co-production, co-creation, whatever term you want to use. And it's about changing that relationship between the professional who knows everything and the patient who's grateful and does as he's told, which has never been the reality, to create something that's far more effective, far more realistic, and far more satisfying, really, genuinely working in partnership. It's a fundamental challenge and principle to decades of history. But I think the health service in Wales is working through it together with its partners in social care and the third sector, etc., etc. But I think, you know, a number of our pieces of work have illustrated how difficult that is actually to make a reality of.
And one of those involved you and I taking many trips around the beauty that is Mid Wales. Just plug us into that project from your point of view, because it came from a request from the then Health Minister, Mark Drakeford, who'd been instrumental in thinking about co-production as a concept in policy terms.
Yeah, absolutely. So this was a piece of work that we did, Mark, didn't we? Probably, what was it, about 8 years ago? Was it something like that? And the key bit of background really was, you know, how to ensure that healthcare in particular and its partners in Mid Wales was fit for purpose. Because I think there had been many years when Mid Wales felt that it was forgotten. Because its challenges genuinely are different. You know, to provide healthcare across the whole of Mid Wales is a very different proposition from in the centre of a city or even in valley communities or wherever else. So it needed a solution designed for its purpose. And there were a number of specific questions like, what is the future of Brongais General Hospital? You know, conventional wisdom would say that how can you possibly have a hospital of 200 and something beds trying to do a bit of everything 50 miles away from the nearest hospital? Couldn't work. Well, the reality is it can work, and it has to work actually, because there's no other way of providing that. But how do you make it work? And linking to co-production, there was the whole issue about how do you go get those communities and their services working together to create a new way of doing things. And this ranged right the way across from, you know, how do you train professionals to work under those situations? What levels of staffing do you need? How do you engage communities in planning for their future? So it was a really interesting piece of work because it made you go back to the beginning and say, well, you know, forget the models that we're trying to impose on this bit of Wales. What does this bit of Wales really need? What does it want? And that was the brief, I think.
And we had a huge amount, didn't we, of powerful representations from those citizens. I mean, it was a very difficult set of messages, I think, for us to hear sometimes because of the amount of passion that people had for their local health service. It was striking to me how vibrantly and they represented those views. And my overriding reflection is that, I think, primarily, but also, being honest, our our sartorial faux pas in that at the presentation of the final report at the National Library of Wales, and we weren't sure, were we, at all how these messages would go down. Inadvertently, you and I had turned up in almost identical, I think, navy suits and a white shirt, and other than for a single diagonal stripe colour difference in our tie, we were almost in whisk uniform. It was so I don't know if that helped in the passing on of the messages. I'm not sure.
No, I was a little bit hurt by being described as Tweedledum and Tweedledee, Mark. But you have to take these things, don't you, in the spirit they're intended.
Broad shoulders, Marcus. Broad shoulders always. One of the things that Whisk has done as well, just thinking about that expert voice of the patient, so some projects like that, but also thinking about how those patients' voices are represented, bits of work for community health councils, did a review, and also a rare-ish bit of work into England, looking at their equivalents at the time. I think they've been superseded now, haven't they, by Healthwatch, but local improvement networks. What's your recollection of those sort of, that group of projects that were all about how individual patients, how individual service users get to have their say, and how effective those mechanisms are?
Yeah, again, another sort of cluster of really interesting pieces of work. And it was, as you say, interesting to work in England and in Wales almost at the same sort of time, so that you could compare and contrast. I mean, the work in Wales, again, we were commissioned to do by Welsh Government at a very interesting time, because already England and Scotland had abolished their community health councils. And yet here we were looking at them in Wales, but very helpfully with a brief not to think about should they exist or not, but simply how to make them more effective. And a lot of specifics came out of that, which were implemented, which I think did improve the effectiveness of community health councils. And of course, they're now about to change again quite significantly to embrace social care as well. But one of the lessons I drew from that was the importance of having some institutional representation of the citizen and the service user, if you like, because whilst health boards and trusts and so on, of course, have a duty to meet the needs of their citizens, they are also having to compromise across a whole range of fronts. And it's really helpful to have a powerful, effective, evidence-based voice to say, we're not interested particularly in the finances of this or the workforce issues. This is what patients and the public want. And that, I think, is a very useful anchor, in all of the sort of complexity of planning around health and social care.
So one of the key innovations that Whisk has been involved in then, Marcus, was around citizens' juries as a particular form of giving power to people, with all of the kind of incumbent responsibilities that a jury has. I'm not sure whether you and Whisk are in the Guinness Book of Records for the first one of those in Wales, but Whisk did hold the first citizens' jury in Wales. What's your view about that as a form of amplifying that voice of the person?
So yeah, I mean, we were lucky enough to sort of bring these to Wales, if you like. They'd been done in England by the IPPR and in America and Germany and so on. So it was not a new idea, but it was a great opportunity, I think, to try it out in the Welsh context, and in particular in health and social care. And the basic idea is you give a tricky, complex issue to a bunch of citizens, and you give them the evidence and you give them time and an opportunity, and they come up with an answer. So the first one we did, as you say, was back in the late 1990s, and we asked a jury essentially what did they want their health service to take from the impending genomic revolution. So that technological revolution, how should it change the health service? And then we've gone on over the years to do a variety of other juries. We did a jury whose jurors were aged between 17 and 19, looking at the question of designer babies. We've done juries on should older people take a daily dose of aspirin. So a whole range of issues. But it's a nice way, I think, of of getting ordinary, in inverted commas, people engaged in some of the complex issues, because these issues do require a certain amount of evidence and time to think it through. But I think what the citizens' jury demonstrates is that everybody can do that. And it's particularly worth doing with ordinary citizens, because after all, the service is there for them, isn't it? So it's a great opportunity, I think.
And I've been involved in the most recent one to be held in Wales, which is actually done all online, not by design, but by need, really, driven by the current circumstances, looking at the future of social care, so measuring the mountain as a project, which is linked to one of the big projects that we're running currently in WISC at the moment, looking to evaluate and understand the impact of the Social Services and Wellbeing Act, which was a big bit of legislation which came into force in 2016, and which has given a legal basis for a number of these things we've been talking about, which is quite interesting, I think. So co-production is a duty now on public bodies to ensure that co-production is enshrined in the assessments that they do and the way in which they make determinations about the appropriate level of support for people. That voice and control and advocacy is part of that, which is what community health councils and all those other organisations you've been talking about. There are now legal duties, enforceable duties for citizens to be able to hold to account the organisations that are there to support them. So we're in a different sort of policy landscape in many ways, I think, than we were 25 years ago, because there were no such duties, there were no such laws that individual citizens could, in theory and in practice, take a local health board or a local authority to court and say, I have the law on my side, my right to these things is not being upheld, and you're asking a judge to make a determination. So it's an interesting parallel, I think, between what is essentially a research exercise and now what we've got enshrined in law in Wales.
Absolutely, Mark. Yeah, absolutely. And I think another dimension of this is, if you like, the emotional, because it's unavoidable and arguably it should not be avoided anyway. So I'm thinking, in the context of a jury, for example, there is something uniquely powerful about hearing the considered verdict of a group of people who have no axe to grind other than that they want the very best. So, for example, we did a jury, a UK jury, looking at the question, should people with serious and life-threatening conditions be given access to medicines that may benefit them before they are approved by the regulator? So we did a jury, we held it actually in Birmingham, and it was a jury of 12 people, 10 of whom themselves had a serious and life-threatening condition, and 2 of them were parents of children with the same. And the power of their verdict, I think, was astonishing. And just like every jury, they don't necessarily conclude what you think they're going to, because they do make their own minds up. But at the end of that process, a number of the jurors went down to London to speak directly to the Medicines and Healthcare Products Regulatory Agency, the decision maker in these things. And the power of that testimony in that room, I can still remember it vividly. These regulators listening really intently to what it was they were being told by the sort of people who would be directly affected by their decisions. That was an intellectual exercise, but it was also an emotional one too.
There's a connection, isn't there, between that evidence base and change in policy that WISC has always been focused on and is still focused on. So in our evaluation of the act that I've been talking about, and in that example, there really is some clear connection between gathering an evidence base, which is what we do as objectively as we possibly can, and then allowing that evidence base, hopefully, to lead change and to drive a new form of practice, because what we've done is trusted, what we've done is independent. That doesn't always lead to an easy audience, does it? And I'm thinking in particular of the Inequalities in Health Fund project, which did give back to Welsh Government a challenging set of messages. It was an interesting project. What's your memory of the inequalities work?
Yeah, so that was another interesting and as you say, quite complicated project. So this was Welsh Government was ploughing millions of pounds into a series of 60 something projects across Wales. And pretty much the only thing they had in common was that they were trying to reduce the inequalities in health gap that blights our society and has done for years and is getting worse. That notion that in any health board area, from one community to another, there can be as much as 20 years of healthy life expectancy. So here were 60 odd projects, a bewildering variety of projects, all doing different things with that aim in mind. And our job was to evaluate that. So, a tricky thing to do. And some of the messages were quite difficult because there were questions, I think, about the effectiveness of this as a programme as a whole. The individual projects, usually they were doing a good job. You could be really inspired by many of these projects doing fantastic stuff. But did that expenditure of millions of pounds of public money narrow health inequalities? Very difficult, I think, to conclude that. But it's a hugely challenging area. That isn't to criticise anybody in particular, but it was uncomfortable.
And it was the first time that you and I met each other. I don't know if you recall, you may not recall the exact meeting. I'll probably allude to something that you may not know in a second. But I was the other half of the coin to you in so many ways. Actually, it's quite a useful metaphor for our relationship, Marcus. But but I think you were undertaking within WISC the independent evaluation. At the time, I was working for a social research company who had been employed to support the self-evaluation of the projects. So I think 67, in total. And at one point, I think I could probably play bingo with them all. I knew the numbers and the names of each of them quite well. But I recall being at a meeting, it must have been like a networking meeting at which you were presenting the approach you were taking to the evaluation, and I was doing my best to support people who weren't really plugged into the world of research and evidence, particularly great practitioners. Their skill sets were their skill sets, but evaluation and research was quite new to them. So I was trying to support them, and I was talking about some evidence or some data set around, I can't remember what it was, cardiovascular risk or something. And I remember distinctly you sitting in the back row shaking your head like, no, he's got that wrong. That's not, either that data's not going to help, or he's making a connection that isn't quite there. And I remember going away thinking, and then we ended up working together for 10 years. So something must have been, there was a signal in that shake of the head that I took away. I think, and delayed transfers of care is another area of, it's a trite phrase that's overused now, but speaking truth to power, there is something about the approach that WISC has always tried to take, which has been to use that evidence base, to use the material that we've got, to not be driven by opinion and not be driven by our own agendas, but to let that evidence base speak for itself. Is that something that resonates with you?
Yeah, and this is another one of those tricky areas, isn't it, really, where you can, if you're not very careful, unwittingly cross the line. Our job, first and foremost, is to focus on evidence. It's to ask the right question, gather the evidence in a robust way, analyse it, and then present it. Because, what motivates us, as we've said before, is ultimately to make a difference, not just to do the research. And that's the motivating factor, I think, is, you want to do the research properly. Of course you do, because if you don't do that, then the rest of it is a waste of time. But having done that, how do you most effectively project the evidence to the decision maker? Because if you don't do that last bit well, all the rest of it has largely been a waste of time. So, I think getting that message across is really tricky. The crossing the line bit is that if you ever get seduced into thinking that your unevidenced opinion is worth anything, then you've made a big mistake. Our job is to project the evidence. It's not to go beyond the evidence. If you ever find yourself in roles like ours saying, well, in my opinion, so-and-so, then you've probably gone too far.
And lots of it comes down to a word that a former colleague of ours, Nick Gould, used to me when I was relatively new at Wisk, which is our role is to create the conditions for implementation. That's what Wisk is often required to do, is to gather objective, independently and evidence-based that is then about that application of research into practice and the implementation process. That phrase, applied research, is used a lot, and I think it's quite a good one to think about us in that particular context, because as you've alluded to, it's not research for its own sake, as important as that is, and it's not to decry that at all, but our particular part of the continuum is about that interface and thinking about and having in mind the people who will be implementing whatever conclusions the evidence has come to, or whatever recommendations we might be saying at the end of a big policy piece, or whatever it might be. And that, having that in mind and holding that in mind, I think it's quite useful for us it kind of keeps us fresh and makes sure we don't get complacent about forgetting the people whose job it is to deliver, whose job it is to support people.
Absolutely, and that's, I think, why it's useful to have a foot in both camps, isn't it? And to have work with people who have worked in both camps and so on, because it does remind you of the constraints which people work within, the cultures that people work within, the motivational factors that make service. I think you do need a good understanding and an up-to-date understanding of all of that if you're to do your researchy bit and project the results across.
What do you then see, thinking about that as a whole, what do you see as the key challenges facing health, social care, voluntary sector services, as distinct from the ones that have been there for the last 25 years over the next 25? Are there particular new challenges? We've alluded to coronavirus and everything associated with that, but do you see greater continuity in the sorts of issues that the workforce and those that they're there to support will be facing, rather than discontinuities?
And that's a really tricky question, isn't it? Because, to look ahead anything more than 12 months at the moment is really hard. 25 years, is mind-boggling. I think the only way you can try to answer that question is to look back 25 years and say, well, how much has changed over that period of time? Because at least you've got a handle on that. And I think when you look back a quarter of a century, I'm most struck by the continuities, really. I think a lot of the things, leave COVID aside, because that is entirely exceptional, but a lot of the things that we are still preoccupied with now, we would have been preoccupied with 25 years ago. The context has shifted a bit, and progress has been made, but a number of the fundamental questions remain. For example, this issue of co-production. It was a huge issue 25 years ago. It's a huge issue now, and I can't believe it won't be in 25 years' time. Hopefully we'll have made some progress, but it presents a series of fundamental challenges to providers. Another is all the issues around workforce. Again, fundamental challenges around resources, particularly finance. Challenges which we had 25 years ago. We've spent enormous amounts of money on the healthcare in the last 25 years, but what are we still talking about? The fact we haven't got enough money. And if you apply that in the case of social care, it's true in spades, isn't it? We have got to get social care on a sustainable footing. At the moment, it isn't, and we can see the consequences of that every day. And that was true 25 years ago. We probably didn't focus enough on it then. We are now. Maybe in 25 years' time we'll have cracked it. I don't know.
That's an optimistic thought. And just struck as you were talking there about the workforce, because one of the things about sitting where Wisk does within the University of South Wales, previously University of Glamorgan, as it was when Wisk joined, is that it is a university focused primarily on the upskilling and the development of the workforce. That is its history many years ago in being the College of the Mind. So it's always had a focus on the workforce. And I think our role, as I see it increasingly over time, is to forge a better connection between the kind of research and evidence and evaluation evidence that we've been talking about, and the learning and teaching experience of undergraduate students and postgraduate students that come through the university's doors. It's making sure that they leave with the kind of knowledge that we've been talking about, ringing in their ear, so when they go into practice in whatever discipline they enter, they've got a sense of, well, you know, there is this evidence base, there is this information, there is this intelligence about how we are operating, how our systems work, and where perhaps even at that individual practitioner level, you can make a difference, not just in co-production terms, in being able to have a what matters conversation with an individual person who might be in a bed or in their own home in front of you, but to understand your role as part of that bigger system.
I think that's absolutely right, and that's one of the things that distinguishes a university, isn't it, from other settings, is that you are undergoing your education, as it were, in an environment where research is also active. You know, there's an old analogy that, you know, that's like drinking from a fast flowing stream as opposed to drinking from a stale pond. You know, there is new knowledge, new experience flowing through the university all the time, in part because universities are research as well as teaching institutions.
Marcus, it's been a great pleasure to have this conversation with you. Thank you for finding the time. Diolch yn fawr I chi. And who knows, I suspect it won't be you or I sat in these positions in 25 years' time. There's something that strikes me about the connections, though, that clearly having an initial M is a prerequisite for being a WISC director, because Morten, Marcus and now Mark are all of that order. All men as well, that's probably worth saying as well. So who knows, it'd be interesting to see someone whose name doesn't begin with M, maybe who isn't male in this conversation in 5 years' time. But it's been a real honour to have that reflection from you. Thank you so much for taking the time.
Pleasure, Mark. And a man of your youth, I mean, could easily still be there in 25 years' time. Have you looked at your pension recently, Mark? You might still be working.
That's actually, yes, I don't, that's a very good point. I don't think I will be of pensionable age in 25 years' time, as the current regulations are, just on the cusp. If I'm still doing this job in 25 years' time, I think something might more fundamentally have gone wrong, but we'll see. Marcus, lovely to catch up with you. Thanks so much for your time.
Cheers, Mark.